Good evening, everyone. Welcome to our fourth and final research club in 2023, hosted by the Brain Health Center of the Rockies. My name is Kathy Kiefer, and I am the co-founder, along with Dr. Augusto Miravalle, of this nonprofit organization. The intent of our research club is to bring the latest developments of recent academic journals and have them explained in a way anyone can understand by a panel of experts in the field. Research Club is a free program to participants, and we welcome anyone interested to sign up online. Please note you only need to sign up once, and you will be on my mailing list for any future notifications regarding Research Club. It is with great honor to introduce our guest speaker for this evening, Professor Robert Motl. He is a professor of kinesiology and nutrition, as well as a professor of rehabilitation sciences at the University of Illinois in Chicago. He has systematically developed a research agenda that focuses on physical activity and its measurement, predictors, consequences, and interventions in persons with neurological diseases, particularly those with multiple sclerosis. His research work has provided the basis for examining the outcomes of physical activity in MS, particularly beneficial adaptations in brain structure, cognition, depression, fatigue, walking disability, and quality of life. Our moderators and co-chairs for Research Club are Dr. Augusto Miravalle and Dr. Brett Fling. As is the case with all Research Club sessions, today's event is being recorded and will be made available via our website in the following days. For this particular session, we would welcome you to use the Q&A box at the bottom of your screen to ask any questions you may have, and we will pose those questions to Dr. Motl within the time frame allotted. Before I turn this over to our co-chairs, I would like to mention our sponsors for Research Club in 2023, which include EMD Serono and Bristol Myers Squibb. You can visit these companies and their products through our virtual exhibit hall on our website. Let's jump into this discussion, fellas. I'm going to turn it over to our moderators.
Thank you, Kathy, and thank you, Dr. Motl, for being here. Truly, it's an honor. I think both Brett and I have been following your research for many decades, and it's great to have an opportunity to have you here and explain and kind of walk us through what you've been doing and what is our understanding. So perhaps we can start with the first question here, which is, what is exercise?
Wow. So start with the hardest question. So when I think of exercise, I want to start a little bit broader and think of physical activity. And physical activity is basically any bodily movement that someone undertakes that results from muscle contraction, and it moves the body, and it results in an increase in energy expenditure. And that energy expenditure is significantly elevated above kind of your resting level. And so lots of things can be physical activity. Taking the stairs, as we were talking about earlier, walking your dog, going, for a leisurely walk around the block. And exercise is one form of physical activity. Exercise is a very structured form of physical activity. It's characterized by a certain modality or type of movement, whether that's aerobic or resistance. It's characterized by a frequency, the number of days per week that you do it, an intensity, how hard you're doing it, and a timing, like how long you'll be doing it, or per duration. And so exercise is something that's very structured, planned, and it's done specifically for health benefits. So when people are exercising, they're thinking, I'm exercising because I want to improve my aerobic fitness, or I want to improve my muscle strength, or, I have any number of other specific reasons for exercising. Whereas, like, to go backward to physical activity, it can be exercise, but it can also be so much more, like raking the leaves right now around your house. They're everywhere. And I spend my entire weekend physically active doing that occupational chore.
Feel like Dr. Motl may have been spying on me the last couple of days, because there is nothing but leaves here in the city of Fort Collins. It's quite a mess right now. I want to just echo Kathy and Dr. Miravali's introduction and say thank you so much. Dr. Motl's work is something that I've been following for a very long time, and since we've started our lab, we've just been playing catch up, trying to follow along in the great footsteps and the work that he's doing. Again, with that sort of specific interest in MS. So Dr. Motl, one of the things that we were talking about as well earlier that I think is always sort of at the forefront of individuals' minds, if they do have maybe some of these neurological issues, neurologic decline, injury, et cetera, and they maybe have a little bit of concerns about their mobility, their safety, a fear of falling, those types of things. What comes to mind when you think of some of the safety issues that need to be outlined and thought of?
Yeah. So, one of the first questions I always get when people are asking about exercise in individuals with MS is it safe? And the first question that comes up is, exercise makes me hot. And sometimes when I get hot, I have some symptoms. I might be a little wobbly, a little woozy. I might have some transient vision related problems and things along those lines. And I think that's, it's a real concern that people with MS should have. And when they are exercising, they should do, particularly if they're thermosensitive and they experience these temporary symptoms, they should do everything they can to avoid them, right? So maybe trying to exercise with a fan, maybe trying to exercise and have a cooling device, like a towel or ice or what have you, just to try to blunt that core temperature change. But, I think it's important to also recognize that core temperature change is temporary, and the symptoms that come with it are temporary, that once your temperature goes back down, those symptoms will go away. Now, I was looking through the attendees, and one of your attendees is Dr. Paludi, and she actually published one of the foremost papers on the safety of exercise about 10 years ago. And when we were looking at this, one of the things that we were concerned about and that we'd seen in the literature a lot was that exercise might increase the rate of relapses, so kind of acute exacerbations of the disease. And to our surprise, when we looked at the 26 randomized controlled trials that we reviewed, there was actually a 26% reduction in relapse rates with exercise training compared to control. And at the time, that was comparable to the effects of some disease-modifying therapies and the reduction in relapse rate. So certainly exercise doesn't increase relapse rate, but there were things that we saw. We saw an increased adverse event rate where people might be experiencing sprains and strains. We saw some back pain, and that was probably one of the most consistent adverse events, safety issues that we saw. The place where we saw the back pain, though, was almost entirely resistance exercise. And so what that says to me is that we need to make sure that when we're having people with MS do resistance exercise, they utilize correct form and minimize the amount of loading, because I think sometimes we confuse the more weight we put on as more important, when in reality, I think doing the movements the right way with lower weight is probably in the long run much more beneficial to anybody, including people with MS. So from a safety perspective, we did see a little bit increase in adverse events, but those were all explainable. And then very recently, Yvonne Lermont, who's out of Murdoch University in Australia, just published a systematic review and meta-analysis on safety in MS, and she included 40 randomized controlled trials that were conducted over the last 10 years. And again, there's a slight increase in the rate of adverse events, these things like back injuries, muscle strains, things like that, with resistance training. But when you look at serious adverse events like injurious falls, hospitalizations, things like that, the relative risk of those events with exercise versus controls was 1.0, indicating no risk at all with exercise training of serious adverse events that result in hospitalization. So I think, Dr. Fling, to answer the question is, exercise is really safe, particularly if you listen to your body and you're aware of kind of some of the way your body responds, and you make adaptations that are appropriate to minimize the likelihood of those things. And I think, everybody would agree that those sort of similar issues pertain to those who don't have MS. I go to the gym every day, and boy, the second I stop doing things the right way, I end up with injuries.
Well, that leaf raking isn't helping my back pain either, but we'll table that for later. As you were talking, I was thinking about this, and I know this is something that your group has looked into in the past, and again, it's certainly not specific to MS, but I wondered if you could talk to us a little bit about maybe some of the benefits and some of the barriers to things like group-based exercise. So as opposed to having to do your own thing from an exercise or physical activity standpoint, what do we know so far about the benefits and maybe some of the drawbacks of getting together with a group?
Yeah, that's a great question. And I think a lot of this, I would put this more in the area of preference, if you could. Some people have a preference to go be in an environment where there are other people around them who are exercising, whereas other people, I'm one of them, likes to just exercise on my own. I like the solitude of going out and going for a run or a bike ride all by myself. And so I think that both of them can be very beneficial for people. But you kind of have to a little bit figure out what it is that you desire the most. So if you're looking for some social interaction, some social support, you're looking for someone that you can talk to about kind of maybe some of the things you're experiencing with MS or in life or what have you, and to have a sounding board, to have someone who's encouraging you, glad to see you're there, right? Like you walk in the door and it's like, cheers, Brett, that's something that will keep you there, right? And you can't have the benefits of exercise if you're not willing to get there and stay there. And so I love that idea of, going to a place where everybody knows your name, you walk in the door and they're happy to see you there. And I think that works for a lot of people. And I think on the other side, though, there are those people who they don't want that. They want to go there. They're very, I think, work-oriented maybe is maybe the right word. They go there, they want to get on the treadmill, get their walking or running done. They get on the bike, they want to get their cycling done or elliptical. Then they want to go straight to weights and get their weights done and then go home and move on with it. The interesting thing, and this is, we'll have really good data on this in a few months. We were funded by PCORI to do this trial called STEP for MS, which was supervised versus tele-exercise for multiple sclerosis. And so one of the arms was really you're exercising on your own, but you had a coach who taught you the routines and supported you every other week or so and your behavior changed, but you were exercising on your own. And the other program was supervised. So you were coming into a gym, you had your coach there were other people there. And we were comparing these two different approaches for delivering the exact same exercise program to look at the benefits. What'll become really unique out of this is that we had two different approaches to putting people into these conditions. One approach, you were just randomized into home, tele, or into supervised, center-based. And the other arm, people got to choose. So you chose, I want to be in the supervised, I want to be at home on my own. And so we're going to be able to directly compare in many ways this preference and this idea of social supported supervised exercise versus exercising on our own relative to adhering and complying, but also the outcomes of walking and cognition and fatigue and other things along those lines. So it'll be really interesting to see the results. And I'm not going to let the cat out of the bag, but Gary Cutter was analyzing all of our data today, and we have a great story coming.
Excellent. Well, that's exciting for sure, and very important research. But I want to bring us back to the benefits of exercise, and one of the challenges of truly measuring that is that any of these lifestyle interventions. Though I argue that exercise should be prescribed, should be part of our medical care, right? So it's something that we can recommend on a daily basis. But if you have to summarize your so many years of research and contributions to this field, what would you say that we can unequivocally say that exercise benefits in terms of not only MS, but in terms of brain health in general?
Whew. That's like 25 years of randomized controlled trials into like one sentence. It's really, it's something that I've really been thinking about, because we've been doing this for about 25 years, and I'm trying to be a little bit of a stamp collector and put evidence into, we definitely know this, we think this, we would really love it if it would work here. And so I'm going to kind of start from a whole disease spectrum. So, there was a large body of research that was looking at exercise effects on the immune system and immune cells. And that line of research hasn't really been fruitful. So studying the effects of exercise on different markers of the immune system hasn't panned out into a clear story that you can say, yeah, exercise changes the immune system. And I think that there are a lot of reasons for that. People are on a disease modifying therapy. That's probably having a bigger effect on the immune system than exercise would in the first place. I hate to say this, but please correct me if I'm wrong. I don't think of MS as a chronic inflammatory disease. I think of it as more episodic. And I think we're studying the effects of exercise on the inflammatory system in between bouts of inflammation. And when people do have a relapse, they're kind of removed from the study and we don't know what happened. But so when it comes to the MS pathogenesis from an immune system perspective, the data are not compelling there at all. When we move towards brain structure, function, connectivity, I think that's where we're really hoping that there's a big effect, right? And I think that we're starting to see people doing the right research and doing the right technique. So for a long time, people were just doing structural volumetric MRI. They were looking at how big a nucleus is, like the thalamus. And, it's hard to change the size of a nucleus like the thalamus that is pretty long-standing structure of the brain and pretty rigid, I think, to a lot of the things we do. But when you start talking about the connections between the thalamus and other areas of the brain, I think we're starting to see more evidence of connectivity related changes within the brain with exercise. So I think in the next decade, we're going to see a lot of data that is demonstrating improvements in connectivity. When we get into functional changes, I think there's pretty good evidence that exercise can improve walking performance in people with MS. So when we look at summaries that are quantitative and qualitative, we see evidence that you can improve walking speed, walking endurance, walking agility with exercise training. I think that exercise, particularly balance and vestibular training, is pretty good for improving postural control and balance. But Dr. Flynn can talk way more authoritative than I can in that area. The one functional area that we're hoping that there's a big change is cognition, right? Like everybody is glommed onto cognition as an outcome right now. And there is a body of research that studied exercise and cognition. In fact, the first study that NIH funded on exercise as a randomized controlled trial that was conducted at Oregon Health Sciences University, where Dr. Fling was a study of yoga and cognition in people with MS. And it actually had no effect. And if anything, cognition actually got a little worse than the yoga. Not to say that there's a nail in the coffin on that one, but I think some of the newer studies, particularly those that are starting to enroll cognitively impaired samples and doing better jobs of putting together really strong, powerful stimuli, are starting to show improvements in cognition. I think so we're moving from kind of the not to the maybe to the we think to where can you put your money? Exercise and fatigue. I think that at this point in time, there's certainly sound evidence that exercise can improve fatigue. Symptomology of symptoms of depression. There's really good data that exercise can reduce depressive symptomology. Then moving over towards quality of life. So that perception of, I'm living a good life, I'm living a life of high quality, whether it's physical or mentally, there are really, really strong data that we can improve health-related quality of life for both physical and mental health. And then there's been a recent meta-analysis looking at participation, engagement in full life activities, working, leisure, things like that. There was surprisingly a really large effect of exercise training on those outcomes. And so when we get down there, we have, I think, a lot of certainty that exercise is beneficial for fitness, it's beneficial for symptoms, it's beneficial for quality of life, participation. It's probably going to prove to be really beneficial for cognition. We just have to get those studies in the right way. It's good for mobility, particularly balance and walking. Probably brain health. I mean, I'm going to put my money there. Like and I'll retire on that too. I think we'll win there, but I think it's going to take some really, really smart people. People who are trained in really good imaging approaches to come together to help answer that question the best. And I think that's in the forefront. I think that's really coming. There was a question in here about, I read somewhere that exercise produces glial-derived neurotrophic factors, which provide neuroprotective properties. Any comments? So, back in the early 60s and 70s, Bill Greeno, who was actually at the University of Illinois in Urbana-Champaign, was studying the effects of kind of these gymnastic type movements in rodents and brain-derived neurotrophic factor and the volume of the hippocampus. And he was even doing things like having these rodents do weight training. So they were learning how to do bench press, and things like that, and showing that BDNF in the hippocampus and the structure of the hippocampus was very plastic and changing with this. And then about 10, 15 years later, Carl Kottman, who's at University of California, Irvine, started doing a lot of work in animals, having them run on a treadmill or an activity wheel, and again, studying the effects of neurotrophic factors in the brain and particularly the hippocampus, and again, showing upregulation. Sometimes this corresponded with their ability to learn to run a maze or things along those lines. And then everybody just kind of glommed onto this idea that in humans, exercise must be upregulating BDNF. It's causing a release of BDNF. And by default, it must be changing around the hippocampus. And this just translates straight over. I think that translation from animals to humans has a lot of intermediary steps that haven't really been solved. And I think that the real question is why is BDNF released when humans exercise that has nothing to do with the brain? And there are simple explanations. It helps with lipolysis or fatty acid metabolism. It helps with thermoregulation and other things that are simpler explanations for why you have BDNF in the periphery. And also BDNF is a very large protein. And the brain has a layer of endothelial cells called the blood-brain barrier that BDNF really probably can't transfer through very easily to have an effect in the brain. I think if we think about exercise and how it changes the brain, And again, I hazard to make these statements in front of Dr. Fling, but I think it's easier to think about when I'm exercising, what's happening in the muscle that causes the brain to be activated and to work harder, to become more efficient, to regulate the body while someone's exercising. And what I mean by that is that you have a number of receptors in your muscles, connective tissues, as well as other tissues and organs in your body that when you're exercising are constantly activated and bringing information to the brain, bringing it into the thalamus. It's being relayed to motor cortex, somatosensory cortex, prefrontal cortex, other areas of the brain, basal ganglia. And they're processing this information. And then they're sending information back out to the periphery to keep you exercising appropriately and safely. When we think about this, that afferent efferent flow of information and processing in the brain is probably an easier way to think about why the brain adapts and explain why we would get improvements in brain structure, function, and connectivity than a neurochemical that's released when a muscle contracts. Just my opinion.
That was a wonderful explanation, and just to reflect a little bit, we have here Dr. Motl and Dr. Flynn. There are two of the most prolific contributors to the field of exercise and brain health. So it's truly an honor to have both of you. And what I admire besides your contributions is the fact that both of you are extremely careful in jumping to statements that perhaps have not been completely proven, even though you both share the same enthusiasm to truly show that exercise is beneficial, right? So whenever you say something is being proven, I take it as a truth because I know that for you to say that, it truly takes years of experience. But talking about exercise more,
I'm going to interrupt for a second. And just say I couldn't agree more. I could listen to Dr. Motl all night. This is right up my alley. So I'm really enjoying these.
Absolutely. But I want to pick your brain a little bit in terms of this concept of dose effect, right? So anytime we have an intervention, we wonder not only the intervention itself, but how much of that intervention relates to the effect. And you recently published a very interesting research looking at both cognitive and physical interventions and divided into 4 different groups, placebo versus no placebo. And for that, you established is the so-called placebo intervention. And it turns out that individuals with the placebo interventions, which was defined as a minimal amount of effort pre-specified to not cause the effect that you were hoping. However, what you've learned, and we all learned from that, is that so-called placebo, actually those patients improved. So can you maybe speak on the fact that, how much of an exercise is needed in order to truly accomplish the effect that you were just describing?
Yeah, so, Dr. Maravale just, brought up one of the saddest days in my life when we, did the analyses of a, 12-country, multi-site international trial in progressive MS of looking at exercise and cognitive rehabilitation versus exercise plus sham cognitive rehabilitation versus cognitive rehabilitation sham exercise versus a double sham on cognition in people with progressive MS. And our hypothesis was double, exercise and cognitive rehab would have a substantially larger effect than the double sham. And when you look at the data carefully, it actually looks like the double sham had a bigger effect than the double intervention. It made a lot of us very sad. But the reality of it is that, and I'm going to get to the dose response question in a little bit. In some cases, in multiple sclerosis, we have people who have severe disease that they're not doing anything. They're not socially engaged. They're not intellectually engaged. They're not physically engaged. They're really kind of disengaged based on kind of their disease and their perception of what they can do and a number of other reasons. And so we took these individuals who basically were cognitively impaired, they had progressive MS, and brought them into a center 2 days a week for 16 weeks and gave them social interaction, gave them attention, gave them cognitive and motoric things. They had to figure out how to drive there. They had to figure out how to get home from there. And I think that one of the things that we really demonstrated is activation in its many different forms can be quite beneficial for all people with MS. And so when we started to kind of think about it differently, we turned that frown upside down into a smile and kind of thought like, okay, we have something good. Relative to this idea of a dose response, there hasn't really been a direct study that's tried to really examine different doses of duration or different doses of intensity or different doses of days per week, or things along those lines in a systematic way to figure out what's the right duration, what's the right intensity, what's the right frequency of exercise. So a lot of what we're stuck with is trying to look at the body of evidence and kind of put it into buckets and figure out what those buckets are telling us, like reading the tea leaves, or so to speak. And so there are a couple different thoughts on that. Most of the data that we've been able to kind of put into buckets and read has suggested that there's really not, at this point in time, evidence for a dose response, but rather a dose that should, if you reach, should yield the benefits that you can expect from exercise. And so that dose is 2 days per week of aerobic exercise and 2 days per week of resistance exercise. And that sounds like a pretty low amount of exercise at this point in time, but that's what the data suggested. With the aerobic exercise, it only was 30 minutes per day, 2 days per week. And, it was a moderate intensity. So working as though you felt like you were working, but not so much that you couldn't, talk with someone, or that you were like out of breath and felt like, the end was near, so to speak. And it could be on a bike or a treadmill or an elliptical or a recumbent arm leg stepper, things like that. And then the resistance exercise was 2 days per week. And we encouraged people to move from like 1 set to 2 sets of exercise, make sure they hit the upper body, the core, the lower body, to get kind of that full body exercise. And again, to choose a resistance that you could do, up to 15 reps, but at the end of the last repetition, you really could feel it and we're like, oh boy, I'm done, and you could do this with free weights, weight machines, things along those lines. But so my point is that was what seemed to be the dose that was the likely to yield the benefits for fatigue, for quality of life, for walking, and those outcomes. Now, we've been kind of snooping around in these meta-analyses, and there are some thoughts that there might be some dose response effects. So for example, a colleague of mine, Matt Herring, who's at the University of Limerick in Ireland, had done an analysis looking at changes in depression with exercise training. And he broke down the frequency of exercise in number of days per week into 1, 2, or 3 or more. And he found that when you went from 1 to 2 to 3, that you doubled the reduction in depression for every day. Now, we didn't have data from like 4 or 5 days, so we just kind of stopped at 3 or more. So suggesting that maybe there's a dose response for depression, but and then we've recently, I was giving a talk for an event up in Wisconsin a few weeks ago, and it was a walking event. So I gave a talk on why exercise should really focus on walking. And so I was giving the prescription for how much walking you should do. And I had a gentleman come up to me afterwards and say, wow, Rob, I guess I should stop running and just start walking. No, that wasn't the message at all. You were not the person who I was talking to. if you're running, keep running. And so I bring that up because there is an advanced exercise prescription that's recently been proposed that is 5 days per week of aerobic exercise that can be performed for up to 40 to 60 minutes per session at an intensity that is high intensity. So up to 80% of heart rate max, 70% of aerobic power, including running and road cycling and things like that. But that's for people who've been exercising long enough that they have good established benefits, they have a good established basis, and they want to get a little bit more out of it, and they can pop up to that prescription. We think that if you do that, you're going to get more, right? But we haven't tested it yet. So I think it's safe to go with the physical activity guidelines of 2 days per week of aerobic, 2 days per week of resistance. And by the way, those can be performed on the same day. I failed to mention that. And 3 days is probably safe as well for the majority of people with MS. 2 to 3 days. I think we're good there.
Yeah, I think that's great. Thank you very much. I don't know if a 12-country multi-site clinical trial or teaching mice how to bench press is more difficult, but I'm impressed with all the different research that's going on out here. Earlier, Dr. Motl, I wanted to circle back real quick. You had mentioned that you had worked on a PCORI-funded study earlier, and I just wanted to let folks know who are watching who might not be familiar with this organization that PCORI is the patient-centered organization, patient-centered outcome research institute. And they are very interested in involving patient stakeholders into the design, the entire flow of a research study. So for those of you who are watching who are interested in this stuff, you can go check out, just Google PCORI, and you can see what they're working on and how you could potentially even be involved in that type of thing, which is, I think, really beneficial both directions, for sure. We're getting a ton of great questions from our audience as well, and so we're going to do our best to make them through as many as we can. One of the things, Rob, that you've mentioned a few times are the types of things that we might benefit from in terms of exercise. So we might reduce fatigue, improve mobility, those types of things. But what if those tend to be a barrier to exercising in the first place? So if we're feeling really fatigued, are there ways to accelerate recovery from maybe some acute exercise or physical activity, or even just some of those chronic components?
Yeah, it's a great question, and it's a question that I hear all the time. I already have fatigue. Isn't exercise going to make me more fatigued? And then if I become more fatigued, how am I going to function? Right? I think it's a real concern that people with MS have. But I think it's a real concern that anybody who has not been engaging in an exercise program, who starts an exercise program, is going to experience for a while. If you are not active and you're not exercising regularly, and regardless of whether you have a disease and you start exercising, it's a stress, it's a drain on your body. And it does cause you to be more fatigued because it takes those resources. But over time, your body adapts and the amount of fatigue that it's causing starts to diminish. And then you get to that point where you start to experience that I exercised and now I have more energy for the rest of my day. Now, some people that happens in 3 or 4 weeks. Some people that happens over 3 or 4 months. And so one of the things that we always talk about is listening to your body. Your body will tell you. If you're aware and if you're listening to your body will tell you when you've done too much. So if you exercise and you're so fatigued that you're on the couch the rest of the day, that was probably too much exercise and you should back it off. And we have people say, like, I did 10 minutes of walking and I was that tired the rest of the day. And so my response is, well, let's back off to 5. 5 is a good starting point. I don't see a problem with 5. And then from there, transition forward. So I think it's all about playing with the recipe based on how you feel and, getting the balance right, so to speak, as you adapt.
How
Dr.
about
Vale, did you have a question?
Yeah, he raised his hand. He's very
No,
Yeah.
sorry, I was going to explain. Sorry for that. I didn't mean to raise my hand. I was just checking the questions and I accidentally rose my hand. But now that I'm here, I was going to ask one of the questions from the audience that has to do with, beyond MS, so Parkinson's, dementia, or even healthy aging. Are these benefits that you're describing for MS, can we say that they apply to other conditions, including, as I mentioned before, healthy aging?
Yeah, I mean, boy, I wish we had the data for exercise and MS that they have in the older adult population of the world, because we'd be in a much better situation, right? When you look at exercise in older adults, there's been so much money from federal government put into research and really high quality, large randomized controlled trials that for like a 20-year period of time, you were just seeing these amazing studies being published every week, it seemed like. And they were showing things like exercise, changes around age-related immune dysfunction. They were showing changes in brain structure, function, connectivity, cognition, walking, and the whole way through. So that's where I get a little bit of my optimism that we're going to be able to show these same things in people with MS. So when it comes to like diseases like Parkinson's, Parkinson's is a neurodegenerative disease of the brain, much like MS is, but they have very different etiologies, and they're treated in very different ways. And I bring this up because, in Parkinson's right now, one of the most exciting trials to happen with exercise in Parkinson's disease is going on right now, where it's called SPARKS-3, where they are enrolling individuals who are newly diagnosed with Parkinson's disease, who are on no medication for Parkinson's disease. And they're doing really, really sophisticated imaging of the dopaminergic producing cells in the substantia nigra to look at how exercise can prevent disease progression in Parkinson's disease. And it's I had one of the sites when I was at the University of Alabama, Birmingham, and I'm still involved in the study. But if this study pans out, the data on it will be really revolutionary for how we manage Parkinson's disease. And so I've been thinking and I've been trying to come up with how we could do a similar study in MS. But the problem in MS is the second that someone's diagnosed, we put them on a disease-modifying therapy right away. And so I think we can do some research looking at exercise and a disease-modifying therapy from very early on. I think that's something that we have to do. And I'm trying to answer this question the best I can, in that the disease and the way we treat these diseases is very different. The underlying causes and factors that explain progression and worsening in these two diseases and others are so different that we have to think about a lot of times the unique way that we have to study it. So for example, and I imagine Dr. Flynn gets this all the time, well, can't we just learn from exercise and stroke? And, it's such a different disease and condition and cause, and the outcomes look so much different that a lot of this has to be disease-specific research in many ways. And that creates some problems and chaos, because now researchers, who have limited amount of time and resources are really focused in one area, and there are other really important critical diseases and conditions that require research attention, but we just can't get to them. Yeah, so someone put in a plug in into it's anonymous. I thought there was ample evidence that aerobic activity increases neurogenesis and improves cognition short-term and over long-term. And I think, and they put a PubMed link in there, which is always great when people share their sources. And I just looked at it real quickly, and I think you have to be careful when you look at that paper, because a lot of it is based on animals. And, you know, a good friend of mine who is a cancer biology researcher said if studying animals was a simple recipe to studying humans, we would have already cured cancer, because they can stop cancer in an animal, but we can't, you know, prevent, cure, stop cancer so easily in humans. And so I think, you know, it's easy to find these animal studies and try to make the giant leap to humans, but I don't think it's that easy. Brett, Dr. Fling, you said you're going to answer that one, or did you just take it off the board?
Oh no, we just slowly remove them as
Okay.
you're answering them all in real time. I just get them out of the way. I wondered if we could circle back maybe to some barriers again to exercise, Dr. Motl, and thinking about you know, we had a nice discussion on thinking about things like fatigue and how that might impact your ability to exercise. Do you have any thoughts around what would I say, like adapted physical activity for folks who are you know, working through different types of maybe musculoskeletal injuries, so hip and knee osteoarthritis, things along those lines? Are there low load exercises that we might consider as alternatives?
Yeah, so certainly adaptive exercise is critical for people with multiple sclerosis, particularly as you move up the spectrum of disability and someone's using, for example, a rollator or scooter or wheelchair, and has real difficulty standing up and ambulating. And I think that there are lots of adaptive pieces of equipment. So, you know, these arm leg recumbent steppers are really wonderful devices. And then there gets to even be other devices, for example, FES cycling, which is functional electrical stimulation cycling, where, you know, you're on this really high quality bike ergometer and you put electrodes on someone's leg, and it activates the muscles so that they can cycle with additional assistance, so they can get a really strong exercise stimulus and things along those lines. So there are like really great adaptive exercise pieces of equipment and programs. The issue is getting access to them, right? So oftentimes you're going to have to go to a clinic and go to a specialized facility to get access to these things. And I think that creates barriers to people being able to utilize them and benefit from those the way that they can. So great technology, but restricted access, so to speak. And the FES cycling and some of these pieces of equipment, some insurance companies will pay for them. So if you know, it's always worth an ask to your neurologist, to a PT, to see if there's some opportunity to get insurance coverage. But I think the one thing that I like to think about when I think about exercise promotion is, and Dr. Miravale will love this, I think the exercise promotion process really needs to start with the neurologist. And I think part of that is that the neurologist, by listening, understanding what a person with MS is really experiencing, can give that efficacy enhancing, confidence boosting initial nudge to exercise, and then help people find the resources that they need, whether those are community resources or home-based resources or facility-based resources, to start to put an exercise program into place, and can also make suggestions on where exercise might be most valuable to them. And then you have the nurse practitioner, you have PTs, OTs, other rehabilitation specialists that can help with the referral process and putting things into place. So I like to think that we all need a little bit of help, and the point of starting this, I really think, is the neurologist, and then moving downstream, because I think that Brett, one of the biggest barriers is the fear of, what am I going to do? Am I going to hurt myself? Is this going to damage me? And if the neurologist can start the discussion and get the right resources in place, I think we can remove those fears and anxieties.
I couldn't agree more. And absolutely, you published actually that not a couple of years ago. You had a publication on neurologists as the first step, which I actually appreciate that. And we only have a few minutes left, but among your many areas of expertise and contributions, you recently led a group to try to understand all of the factors involved in exercise, not only those effect and benefits, but also how can we help patients go through the process of change and sustain their efforts, right? So one thing is to say, you need to do this. But the other thing is for patients to be able to not only accomplish that, but sustain that benefit. So can you perhaps tell us in the next few minutes, not only where would patients should start to exercise, but what is the recipe or formula to maintain that effort?
That's really another whole segment, but I'll give the Cliff Notes version. I think the problem with many approaches to try to promote exercise in any population is we just say, here's the program, go do it. And, that's a very daunting task. If we set up a program that we say, okay, here's a graded program, we're going to start really small, simple, and move towards, and there's a question in the chat on this, something that's more involved and maybe complex over time, and give a really nice staged approach to moving through a regimen. That's the first step. We have to give someone something that they can do, they don't feel overwhelmed with, and they can have a success. They can do it and feel like, wow, I accomplished that. I did exactly what I was supposed to do, because that accomplishment, that success makes us feel good about it and makes us feel empowered to be able to do the same thing tomorrow and the next week as we move on. And what I'm getting at is we have to give people more than just a prescription. We have to give them tools. We have to give them the support structure, whether that is a prescription with, we call it action planning, but it's nothing more than giving people a calendar, having them write when they're going to exercise on there around their busy days and lives, and sticking with it. And after they do it, cross it off. And then you get feedback that you did it. We call this self-monitoring, but it's nothing more than journaling. When you're done exercising, you write in your logbook what you did and how you felt and your successes, right? So the point is that it's not just giving people a program, but giving them all the tools and the resources and the strategies and techniques that they can put that program in place and then maintain that program over time. And then also have tools, because we all have this. We all have relapses, whether they're a disease relapse or, we get sick or we go on vacation and our exercise program stops. And then we have to start it back up again and get back on. And you have to teach people the skills for preparing for relapses in an exercise program brought on by a lot of different things. I do, if we have a second, want to address a question that was in the Q&A. And it went away, but the question was, can we get greater benefits, particularly within the central nervous system, with more complex exercise regimens? And I think the answer to that is 100% absolutely. And I think to a study that was done a few years back on an approach called square stepping exercise. And what square stepping exercise is you're given a 4x10 grid, and you're taught to do these stepping procedures in this grid. It's kind of like Dance Dance Revolution or other things along those lines. And you're taught these simple movements, and then you go home and practice them as your exercise routine. And then 2 weeks later, you come back and they tested you. Could you actually do these routines? Did you learn them and really perform them? And once you pass the test, they give you more complicated movement patterns. And you have to memorize these and perform these complicated dance or step sequences. And once you're good at it, for 2 weeks, then we give you more complicated ones and more complicated ones. And what the researcher found in that study is, compared to an attention kind of stretching control condition, that you were able to get improvements in both cognition and motor function simultaneously. So the idea of giving a complex stimulus that activates motor and cognitive processes and balance, bringing postural control into all this, really maximize the amount of information going to the brain and cause the brain to have to adapt in a much more robust and meaningful way to get these adaptations. And I think we need some neat programs like that. And I know Dr. Fling has a background in kind of some of these unique virtual programs, virtual reality and things like that. So we need more of those kind of programs to test that hypothesis.
Yeah, I really agree. I was actually going to say, you mentioned a study that we were a part of in Oregon several years ago, looking at something like does yoga improve cognition, and it showed no benefit, or if anything, actually maybe the wrong direction. So we took that to then make it more complex and began doing much more what we would call dual task movements with individuals, where they were doing things like boxing while being asked cognitive questions and having to do multiple things at the same time, and found radically better results. I think your assessment is right on the money, Dr. Motl. I know, Kathy, I know we're up against it, so I don't want to take too long.
Well, I have to say this was fantastic, and I love this entire discussion. Dr. Motl, a huge thank you for shedding some light on the recent research that is being conducted in this area of exercise. And I thought it was great having you, Dr. Fling, as well, to contribute with your comments, since you have quite a bit of experience in this area as well. So fantastic. Thanks to my two co-chairs. And of course, I'd like to recognize our sponsors for Research Club again, which is EMD Serrano and Bristol Myers Squibb. We have not posted our topics for Research Club for 2024 as of yet, so please stay tuned, and we will, hopefully before the end of the year or first part of next year, have those posted on our website. So please check our website for those updates. And we look forward to hopefully having everyone back with us next year. So have a great evening. And again, many thanks, Dr. Motl. This is fantastic.
Thank you.
Night, everyone.
This is a lot of fun.